we will have the next speaker, which is Professor Igor Maldonado, share his presentation with us. And while Igor is doing it, which are nearly there, I'd like to say that for those who don't know Igor, he is originally from Brazil, works in Tours in France. He is an excellent neurosurgeon in the old sense, but also very clever with his hands with wires and tubes, i.e. endovascular surgeon, but also an expert radiologist. And I think this is a perfect mix for a person to tell us about cerebrovascular anatomy. Igor, are you there?
Do you hear me?
You can hear fine. Try to be as close to the microphone as you can be. There's a bit of echo.
Okay, is better now? So thank you, Tom, and thank you all guys for this fantastic experience. So many of you remember the contributions of Egas Muniz to the development of cerebroangiography in the beginning of last century. At that time, cerebroangiography was performed by direct puncture of the carotid artery without any kind of subtraction. This guy shared a Nobel Prize for development of a frontal leucotomy. As you see here, it was one of the most controversial Nobel Prize ever awarded. Of course, he could have won the prize years before because of his contributions in detecting intracranial pathologies using cerebroangiography. At the present days, of course, we rarely perform a direct carotid puncture. We employ mostly a femoral approach. The operator certificates that is inside the lumen of the artery, not the vein. And then, with the help of a guide wire, the needle is replaced by the sheet, as you see here. And once the sheet is in place, the operator can introduce the angiographic catheter and navigate in the vessels until the neck or the intracranial space, mainly through the carotid or vertebral arteries. The catheter progression is followed in the angiosuite, the vessels are ossified, and then you get two-dimensional images such as this one or this one very amplified with bone subtraction. So one of the first important concepts and the vascularization of the cephalon is the fact that it is organized in two connect systems. One is the anterior or anterior carotid system, and the other is the vertebrovascular system. And both are connected by the polygon of Willis, which is also described as the arterial cycle of the brain. So the vascularization of the encephalon derives from the arch to arch, which presents certain number of variations. Some of them are quite rare, others are relatively common, and we see times to times. And some of them can be really a challenge for catheterization. So the first one you see here is the general pattern. So some other relatively common, as you see here, as in the left primitive or common carotid artery that is emerging quite close to the brachiocephalic trunk or even together, or a vertebral artery that emerges directly from the crossa, from the aortic arch, completely detached from the subclavian. And this is one more rare, but we can see time to time when we do a lot of angiography, you see that the right subclavian artery is coming completely distal to all those large vessels. Here we see an image of radiography, and you see once again the most common presentations. In the angiogram, we recognize the innominated artery, so the TABC, the emergence of the vertebral artery just proximal at the level of the superior aspect of the subclavian, just before the internal thoracic artery. You see the primitive or left common carotid artery, the left subclavian, and the vertebral. So in a young subject, the ICA generally takes a position which is posterior in relation to the external one. It's of course also slightly lateral, and then comes medial as it comes to enter the carotid canal. In the young person, it's better to distinguish left and right carotid in lateral view. And then as the anatomy changes with age and vessels get elongated, the bifurcation tends in most people to get coronalized, and then the AP view often becomes better in elderly people. We recognize then also the internal carotid artery by the presence of the carotid bulb, which is a very important physiological site for bioreception, and then by the fact that in almost every case we have no branches for the internal carotid artery. Quite rarely, I think maybe I saw only once, you can have an ascending pharyngeum coming from the internal carotid artery, but it's really exceptional. And then at the level of external carotid, you recognize the branches in the usual order, such as the superior thyroidal, facial, lingual, and then you see in the posterior aspect the occipital artery. The carotid bulb is a site for change of velocity of flow, and also is a site of wall stress. So it's a vascular site that is prone to atherosclerosis and thus atherosclerotic stenosis, as you see here. As the ICA penetrates in the skull, it presents several segments that must be recognized. There are different ways to classify them. The different classifications were proposed. I am not going to show all of them in this lecture. It is a knowledge that is still evolving. These are the classifications that are accepted in most centers, but it's quite variable from one place to the other. As soon as the ICA penetrates in the carotid canal, you have the petrous segment, and you may also talk about a lateral or precavernous segment. And then when it enters the cavernous sinus, it curves to ice, and you have this horizontal and vertical portion inside the cavernous sinus. And then the anterior clinoid is here, and you have this supraclinoid portion. So the carotid artery is getting inside the subarachnoid space and is getting also trigeminal innervation. This Fisher classification is very well accepted in the radiological domain. So you see the segments are numbered against the direction of the flow from distal to proximal. And so we recognize here the anterior choroidal artery, the posterior communicating artery. So everything is superior to the proximal wall stream of the posterior communicating artery is called C1. C2 corresponds to the ophthalmic segment, and then you have C3, C4 for the vertical and horizontal portion of the infracavernous carotid, and C5 you have precavernous segment. So I think that the best way to deal with different classifications is to use not only numbers but also vernacular classification. So every time we should describe it, we should use terms to describe it. Gibault and Boutillier are more recent classifications, but are quite different. You see that the segments are numbered in the direction of the flow. They do not correspond perfectly. Interestingly, in the Boutillier classification, you have a small segment for the clinoidal portion. And something that is important is that for more precise classification of this subarachnoid portion, subarachnoid segments, there is a subdivision which is generally used. You see maybe here in this publication from Professor Rotton's group. We can refer to an ophthalmic and communicating and choroidal segment. The ophthalmic segment comes from the emergence of the ophthalmic artery, which is the usual classical landmark for the roof of the cavernous sinus. So from the proximal rostrum of the ophthalmic artery into the proximal rostrum, just before the emergence of the communicating artery. Then we can talk about a communicating segment from the proximal emergence of the communicating artery, posterior communicating artery, just before to the anterior choroidal, then the choroidal segment, and finally the carotid bifurcation. Well, that's what we see in this angiogram, lateral view. We can recognize those segments. So ophthalmic, communicating, and choroidal. So note these aspects and change of diameter of the posterior communicating artery. It's very classic. and when the Willis polygon was well formed, you see the point in which contrast gets out of the posterior communicating artery and gets into two segments of the posterior cerebral artery, and you see there is some contrast washing here, and then the very typical bifurcation of the PCA. And then for the anterior choroidal artery, you see it's much smaller, much thinner, and you have this typical ascendant trajectory as is going to get very close to the base of the brain, very close to the optic tract, and you have very teeny, small branches that will work as perforators, and some of them are very important to, as you know, to the posterior limb of the internal capsula. So is also in this angiogram, we can see some tiny, very tiny vessels that we don't see in every angiogram. Some of them are very variable, and so there are embryological remains, such as the beniglo VGen, but we can also have some tympanic branch or stapedius artery. But the important ones are those that are coming from the cavernous segments, such as infralateral trunk and meningohypophyseal trunk. So this is the most common pattern. The meningohypophyseal trunk gives some long branches to the clitoral and the dura of the clivus, such as the medioclival branch, as you see here. And the infralateral trunk gives branches to also to the clivus. You have a small lateral clival artery, but also branches to foramens of the slow base. And often you have anastomosis with the ophthalmic artery. So two branches I would like to detail for the infralateral trunk, are quite interesting, or those two here, the basotentorial artery and the marginal-tentorial artery. Those are, as I mentioned, the branches that we don't see every time in angiograms, but they may be enlarged when you have some slow-based pathology, such as tumor, AVM, or fistula, such as this case of arteriovenous fistula of the transverse sinus. So typically, they come from the intracavernous portion, horizontal portion, and they have this small tortuosities, and the trajectory is roughly posterior and superior. So you have this clinical, this typical inclination, and it's very difficult in a lateral view to be sure which one is the basotentorial artery, which one is the marginal tentorial artery, which is at the level of the free edge of the tentorium. But when you take a look at the AP view, it becomes really easy because you see that the marginal tentorial branch, is also known as the artery of Bernasconi Casinari, draws for us the free border of the tentorial, as you see here, which will be never the case for the basal tentorial branch. So in this view, we can recognize the ophthalmic artery. As you see here, as I mentioned, is a classical landmark from the roof of the cavernous sinus. Something important that's in later phase, we can see the choroid blush that is filling from the ophthalmic artery. In some cases, mostly when you have atherosclerotic pathology of the ICA, the carotid blush may not come from the ophthalmic artery, and may come mostly from anastomosis from the angular artery, which is a branch of the fascia. In most of cases, more or less 85%, the ophthalmic artery runs under the optic nerve and crosses from medial to lateral to medial, sorry. In a smaller number, it can have a more tortuous trajectory, and it comes to medial to lateral. Another important fact, which is not a detail, that even though the ophthalmic artery is used as a classical landmark for the superior limit of cavernous sinus, it's not a perfect landmark. There may be variations. The emergence part of the artery may be intracavernous, and may be higher than usual. And we must be aware of this dural space along the medial aspect of the ICA, the carotid cave, which is due to the fact that the distal dural ring is not exactly at the same level in all parts of the clinoidal segments of ICA at this point. So the limits of the cavernous sinus at this exact point is not horizontal. As a consequence, if you take into consideration only this classical landmark on angio for an aneurysm of this region, an aneurysm may be a small aneurysm, may be mistaken as an intracavernous one, but in reality it's a subarachnoid one in the carotid cave. Also, from this region, of course, we can have the emergence of the hypophyseal arteries, also superior hypophyseal, which also can be possible origins of aneurysms. So when we continually see superiority, we see the arteriochoroidal artery, and then posterior communicating artery, and then the anterior choroidal artery. And I'd like to
please come near the microphone.
Okay. So I'd like to take some minutes to show you some of these interesting angiographic variants. You see, as I mentioned before, the very typical change in diameter. You see the PCOM and then the P2 segment, and this is something like we would like to see every time, such as we see in the books. You see contrast coming to the PCOM, and then you see beautiful washing, and you have almost no washing here. So of course it's difficult to prove before injecting the vertebral artery, but very probably you have a very small or even absent P1 segment here. And then you can have even very tiny PCOM, as you see here, or even maybe even absent, as in this case, with an enlarged emergency, as this case of the infundibulum, and then a very large PCOM, which has the same diameter of the PCA. The P1 may be completely absent here, and this is what we call a fetal variant. So the variants at the level of polygonum are very common. When you do a lot of angiography, you see mostly or asymmetries of communicating arteries, asymmetries of the anterior communicating complex. You see here both A2 filling from a single A1, hypoplastic A1 from one side, azygous A2, dominant vertebral, which is the communication between the vertebral and the basilar, maybe very tiny or absent from one side, fenestrations, and even more strange things that you can see here. Contrast was injected inside the internal cerebral artery, and then you see that part, the superior third of the vertebral of the basilar artery is very well opacified, and you see even the superior cerebral artery and PCA, and is not the posterior communicating here. So what is this? This is persistence of the trigeminal artery, which is an embryonal element. So if we take a look to the distal branches, by matter of time, I will mostly focus on the anterior circulation. You have, which is a continuity of the Fisher classification. So for the anterior cerebral artery, we can also identify segments. We see A1 pre-communicating, A2 post-communicating, which also infracallosal, A3 precallosal, which surrounds the genu of the corpus callosum, A4 supracallosal, and A5 posterior callosal, which many times anastomosis with the posterior callosal artery. Posterior callosal artery comes from the PCA, so you have an entire circle that may be present around the corpus callosum, and the emergence of the callosum marginal artery, which is also quite variable, sometimes more inferior, sometimes more superior. So let's see, take a look at this in angio. So you have A1, A2, once again, A2, A3, A4, and then the connection of the posterior cerebral artery. So let's take a look again on this practical angios we just said about the variation of the polygonal billies. So what's happening here? The two systems, left and right, are completely disconnected. So probably anterior communicating artery here is very small or even absent, what can be confirmed by doing a contralateral compression common carotid during injection of contrast median. Here we have the opposite, so you have a very well developed anterior communicating artery. So both HUs are filling from the same carotid and from the same A1. So what we have to confirm here when we inject the other carotid is if there is asymmetry of A1 segments, which is important information for both embolization or surgery of an aneurysm of this region. Here in this MRI imaging, also interesting, you see like a nasogos artery, but actually you still have a communicating artery which is fenestrated here. You have a nasogos here. You have asymmetry. We had asymmetry of A1 segments in this case. Both arteries, both HU filling from the same side, and an aneurysm there. For the middle cerebral artery, same thing, Fisher classification. So M1 is the horizontal portion, the sphenoidal portion. So it's not only up to the bifurcation, it's really the sphenoidal portion. So it means that if you have an early bifurcation with a very short trunk, it is still M1. So M2 is the insular portion, and then you have this very closed cord, and then you have opercular, cortical, and terminal branches. So what is interesting to see is for all of those branches, not only the middle cerebral artery, is try to see the anatomy behind the vessels, not only the vessel. So when you see this front angiogram like this, and you see the transition M1 and 2, we know that this transition is the level of the ligament of the insula. So let's imagine here the ligament of the insula. So I know the basal ganglia are there. Those are lenticular striates. Then we have the insular branches. I see the insula gyri here. If you take a look of the lateral angiogram we see in the left, you can even imagine you see that vessels are depicting for you the anatomy of the gyri and sulci of the insula, and then those M2 branches, they will turn sharply to contour the frontal and parietal operculum, and of course the temporal operculum also, and all those change of directions will draw for you this triangle, which is the insula. So different angiograms, same thing. You see all those changes of direction, and the last change of direction will correspond to the posterior ciliary point. Some variants. So we have N1, quite long one, transition M1-2, an early temporal branch with an aneurysm, is a trifurcation of pseudo trifurcation. Same thing also with an aneurysm. An early frontal branch, so M1 will be up to here, and then you see a level is early frontal branch and aneurysm. More strange thing, we have here an early temporal branch and the M1 level. It was a very, very difficult case. It took also some time to understand. Fenestration in the trunk, in M1 segment, and inside the fenestration, a small aneurysm emerging, and then with a lot of lenticular striated arteries there, and even one of them was coming from the aneurysm itself. So posterior cerebral artery, also classification in segments, pre-communicating P1, post-communicating P2 with pedicular and quadrigeminal portion. So we can talk about, pedicular and ambient portion. So we can talk about P2A and P2P, and then P3 quadrigeminal and P4 cortical and terminal branches. So really interesting how this anatomy also draws for us, once again, the cortical, the parenchymal anatomy behind it. So usually in lateral angiograms, you have this aspect of the artery is ascendant, and this, as you go posterior, is going to be more and more separated than to the branches of the superior cerebral artery. So, because these branches will be under the tentorial and will draw for you the tentorial surface of the cerebellum, and this you have a passage up to the tentorial. Sometimes you have a kind of abrupt change of direction. I have this in one of the next slides, which is drawing for you the exact point of the border of the tutorial is. And then very typically posterior, you have this Y shape of bifurcation, because one of the continuity of the artery, one of the branches will get inside the calcareous fissure. So it's drawing for you the occipital lobe, and you know that the lips of the calcareous fissure are there. So this is lingula, this is cuneus, and the other branches will get inside the parieto-occipital sulcus, and so you know this is precuneus. So same thing. Unfortunately, we don't have time. It will be time for another lecture to detail all the vertebrovascular system. We still have the venous system, but we'll have a lecture on the venous system with Professor Victor Hugo in some minutes. And you see here the very typical bifurcation I just showed, and of course all those branches we can come with. For the basilar, we see is here the superior cerebral artery, superior contralateral one, duplicated, bifurcated. We can have also duplications of all of those arteries. And also in this vertebrovascular portion, the artery which is most prone to variations is the vertebral artery. So in the Fisher classification, we recognize 4 segments for the vertebral artery. One is the prevertebral segment, which is from the origin, from the superior aspect of subclavian, up to the penetration in the first lateral process, transverse process, which is usually the transverse process of C6. Then you have this vertebral interforaminal segment, which is quite vertical. And then when the artery leaves the transverse process of C2 to get it into the foraminal, this is the atlantal portion, so V3. And then you have many times a small constriction here, and you know that the artery is getting inside the dura, and you have V4 segment, which is intradural one. So this is, as I saw, you see the changes in direction I just showed you. So for sure, this from here, I'm already completely out of the foramen of Pacchioni. So this is what I just showed you is quite variable. You see that in this case we have a small dominance of vertebral arteries. They are quite symmetrical, but they're not really symmetrical. When we have vertebral artery dominance, in most cases, the dominant one is the left one. And what happens to the other? We can have just a smaller one, but it is still working as a vertebral artery with a confluent to the basilar one, or you can have a very small one, tiny one, which is completely finished in pica, often a large pica, and you may have no communication with the basilar at all. So when we have this kind of pattern, most cases is leftward than rightward. So it's something we should check before embolizing or operating vascular lesions of this region. So that's what I wanted to show. I hope it was useful. And once again, it's a fantastic experience. And thanks a lot.
Tom, unmute yourself.
I'm hearing you.
Yeah, I'm sorry. So again, thank you very much for your presentation. It has covered a lot of ground again in a very short period of time. We don't have a huge amount of time left, and a lot of it was self-explanatory. I can't see any very burning questions that we really have to go through it. I can see